Thanks everybody for joining the CACCN BC chapter. This is our roundtable for the fall. I'm grateful to be joining from the traditional and unceded lands of the Secwepemc people here just outside of Kamloops. Because we're joining from all across the province, I invite everybody to reflect on the lands that you're joining from today. We have an excellent lineup of speakers today. First up, we have Kelly Bubb from BCIT, who's going to teach us a little bit about the cerebral oxygen supply and demand work that they've been doing.
My name's Kelly Bubb. I'm faculty at BCIT in the Specialty Nursing Critical Care program in the School of Health Sciences. I've worked there for about 1.5 years at this point. Before that, I worked at VGH ICU for long time, since COVID, I think. And then I previously worked in Edmonton in ICU as well, in their general systems and burn ICUs. And then before that, I worked at VGH in their high acuity unit for burn trauma and high acuity. So yeah, I made the move to BCIT and I love neuro patients. So I very much enjoy this work that we're doing today, and then I'll introduce you all to today. So we'll be going through BCIT's Cerebral Oxygen Supply and Demand framework. BCIT has rolled out a new revised curriculum within our critical care program, specialty nursing program. And what we've done with this framework is we've integrated the foundational principles of neurocritical care nursing into our classic oxygen supply and demand framework. And this in a way that aligns seamlessly with its structure. This enhanced approach helps clarify the key interventions used to optimize cerebral oxygenation and prevent development or worsening of a secondary injury. We believe that the treatment of an acquired brain injury, whether traumatic or non-traumatic in nature, is built on 3 foundational goals. We want to treat the cause, we want to optimize the cerebral oxygen supply and demand, and then we want to monitor and prevent for secondary injury, as those can be quite fatal for our patients. This presentation and the interventions that I'm going to focus on are more aimed at sites across BC where they don't have the advanced monitoring interventions that necessarily are done at VGH ICU, but I'm going to go over some principles that can be applied regardless if you have direct measurements of intracranial pressure, and so just basic ideas of how to manage a patient who's undergoing an acquired brain injury. So today we'll go through a quick overview of the Monro-Kelly doctrine, as this kind of guides how we've implemented this into the framework. We'll then go over our specific cerebral oxygen supply and demand framework as we've presented it today, or as of right now, as we've created it. Then we'll go through some interventions based on different aspects of the Monro-Kelly. I'll have time for some questions, and then we'll go through a summary of what today was. So the Monro-Kelly doctrine basically is grounded in the idea that your skull is a fixed box that encases the brain, CSF, and blood. Because it's a rigid encasement, this really limits the capacity for any sort of compensation within one of those components, so your brain, your CSF, or your blood. So this is the concept that leads to this Monro doctrine, or Monro-Kelly doctrine. The total volume within the skull must remain constant, and an increase in one component necessitates a corresponding decrease in the volume of one or both of those components. If the accommodation cannot match the increased volume, we're going to see an increase in intracranial pressure and the development of secondary injuries. So we'll just touch base on how accommodation works in these 3 sectors of the brain, and then we'll move forward, or 3 components of the brain. So when there's an increase in brain volume, usually due to space-occupying lesions or edema, the brain tissue is going to shift. And that shift can be tolerated very briefly. However, it's a very limited capacity for your brain to tolerate this. And so if the shifting is left unchecked, you're eventually going to lead to herniation. And herniation is where the tissue moves through the intracranial structures and compresses surrounding areas, which is the brainstem is our most important and most concerning area. In regards to CSF, just as a reminder, because it's been a while since we all done patho, it's produced in the choroid plexus and is reabsorbed in the subarachnoid space by the microvilli. Anything that disrupts the function of these subarachnoid villi, so inflammation, blood, debris, obstruction, will impair reabsorption of our CSF and can lead to CSF accumulation, or what is called hydrocephalus. When CSF volume increases or hydrocephalus develops, some fluid can be shunted into the spinal cord, but this compensatory mechanism is also very limited. And then finally, in regards to our blood, the ability for our blood flow to compensate relies on cerebral autoregulation. Cerebral autoregulation maintains stable cerebral blood flow and pressure despite fluctuations in systemic blood pressure. When it's functioning properly, arterial vessel diameter adjusts to regulate flow. It'll vasoconstrict when perfusion pressure is too high and vasodilate when it's too low. This will ensure that the brain receives a consistent supply of oxygen and nutrients regardless of what systemic blood pressure is. Autoregulation is thought to be governed by the stretch receptors in our blood vessels and by our CO2 levels in our blood. CO2 acts as a potent vasodilator, so it's something that we can help manipulate in managing these patients, and we'll go further into that coming up. So why does this all matter? Well, in understanding these concepts, or the Monroe-Kelly doctrine, and then how to manipulate the factors that impact it, we'll be able to monitor and optimize our cerebral compliance. So this cerebral compliance curve basically shows that as intracranial volume and pressure increase, cerebral compliance will become compromised. And so as you can see on this side down here, we've got high compliance, compensation's working, our brain's able to do what it's supposed to do. And then as we get an increase in our intracranial volume and our intracranial pressure, we're going to get a steep curve and we're going to hit this inflection point. And when we hit this inflection point, anytime any small increase in ICP or intracranial volume is going to lead to a large rapid increase in ICP. And what this means for our patients specifically is it's going to reduce their tolerance for stimulation. It's going to increase their need for sedation and analgesia. It's going to mean we're going to have more frequent vasopressure titration to maintain our cerebral perfusion. And that there's going to be an increased risk of secondary injuries such as ischemia, herniation, cerebral edema, and eventually it will lead to collapse of our cerebral microvasculature, which you see up here, and ultimately death in our patients. So that's why these are all very important. So in keeping with those principles, BCIT and our faculty in the critical care specialty nursing has revised the Cerebral Oxygen Demand framework as shown here. So previously we had just focused on this part here with cerebral perfusion pressure. We didn't really go too much into depth, including our arterial oxygen content and our cardiac output factors. So BCIT has long time had our oxygen supply and demand framework, and that is our overarching perfusion for our whole body. And it really well outlines our cardiac output and all of these factors that determine our arterial oxygen content. What we've done now is embed the idea of neurocritical care management into the framework. So everything is now put together to show what really is impacting our oxygen supply. So the upper aspect of this framework is all for our oxygen supply or cerebral oxygen supply. And then everything on the lower end is determining factors of cerebral oxygen demand. And then the balance between these two will determine our end organ perfusion of the brain. So essentially our cerebral oxygenation. To review this further, we're going to first look at demand management, and then we'll go into supply manipulation as well. So for demand management, the aim here is just to to decrease our demand as much as possible. So we have two main key approaches when trying to minimize demand. We want to only do essential interventions for these patients. We want to minimize our stimulation as possible. And then unlike all other critical care where we like to cluster our care, we're going to try and space out our interventions just to try and allow any spike in ICP to settle and not be sustained. We can do this through stress management in the ICU environment, try and lower noises, stimulation areas that patients are in. Temperature-wise, we can manage temperatures, try to keep them normothermic, try and manage any shivering with analgesia sedation. And then physical activity, if they're having seizures, try and manage that with anti-epileptics, as well as just decreasing our nursing care to an appropriate level where we're not constantly stimulating the patient. When it comes to sedation and analgesia for these patients, our overall goal is going to be administering the minimum amount of medication required to achieve their therapeutic goals without over-sedating them, because we do still want to keep a close eye on their neurological status. We're often going to combine both sedation and analgesia to try and minimize their metabolic demand while still being able to assess them appropriately. For supply, so as you can see here on this framework, this circled area is essentially the Monroe-Kelly components. Our oxygen supply is determined by our arterial oxygen content and cerebral blood flow. So while we are all familiar with the manipulation of this factors that affect our arterial oxygen content, such as gas exchange, ventilation, our hemoglobin levels, and the factors that will affect our cardiac output and how to optimize them to maintain adequate MAPs, ICP managers is where we're aiming with this framework to really help guide our interventions. We're able to manipulate these factors individually as well as together to help lower ICP to maintain our cerebral perfusion. We'll move into each component and its manipulation to optimize oxygen supply now. For brain, how do we manipulate brain? So there's two main avenues, one of which is surgical interventions here, as you can see at the top. We can manipulate brain by doing a craniotomy that's going to remove part of the skull and allow the brain to shift and expand and swell how it wants to. We can do surgical removal of space-occupying lesions. That's more not nursing related. That's going to be our MDs. What we can really affect as nurses is trying to reduce cerebral cellular edema. And we can do that in two main ways. We want to create a hypertonic solution or hypertonic environment for these patients. So we will generally target higher sodium goals for them. So greater than 140, sometimes even higher than that. We do this with not only serum target goals, but by administering 3% saline. Some sites have 5%. It really just depends on what your site has. We can also manage cerebral edema if we're in an acute ICP crisis, the patient's not really doing well, by administering osmotic diuretics. So that would be your mannitol. Both these medications can be given in an ICP crisis as bolus doses. And then your 3% can actually also be given as a continuous infusion just to try and keep your patient on the salty side. I like to say keep them salty. The main concern with these drugs when administering them is they can cause rapid fluid shifts, which is what we want in the brain, but might not necessarily be great for our cardiac patients, which is something to keep in mind. For CSF manipulation, the only real way we can manipulate our CSF is through drainage, and that's placing an external ventricular device. This is literally just a drain that sits in one of your ventricles in your brain. It's called an EVD for short, and it allows us to drain. It allows us to transduce as well for ICP monitoring, so we can trend. It's very site dependent. We want to make sure that it is open when there's an acute vent going on. If it's closed, we want to target a certain ICP. And so that'll be all be ordered by your doctors. And then anytime your ICP is above whatever the target ICP is, it'll drain CSF to try and help shift and try and reduce intracranial pressure. A lot of the indications for EVDs are intracranial hypertension, TBIs, subarachnoid hemorrhages, hydrocephalus. And then if it is transduced, we're actually able to see real-time ICP monitoring, and that's going to reflect our brain's compliance and any changes that are occurring within the skull. So it does help us with quite a lot of monitoring aspects and seeing how effective our interventions really are. But again, this is site dependent, depends on where you are in the province as to if this is something your site can use. And then blood manipulation. This is another main one that we can do as nurses. So when we want to manipulate blood, there's two factors that we can manipulate. We can optimize our venous drainage, or we can manipulate our arterial size. So venous drainage, one of the main interventions you'll see is positioning, just basic positioning, keeping the head of the bed up 30 to 45 degrees, maintaining the neck in a neutral forward position, so you allow all the drainage of the neck vessels. And then if your patient is in a C-spine collar, just make sure it's fitted properly, it's not on too tight, that kind of thing. All of this is going to help promote drainage through here. We also want to minimize the amount of PEEP we're using. So PEEP is going to increase our intrathoracic pressure, which could then delay or limit the amount of venous drainage coming from our neck or from our head to through our neck. So we want to minimize our PEEP as much as possible while still ensuring oxygenation is fine for our patients and ventilation is occurring. So Sometimes you'll just go on a little bit higher FiO2 to try and reduce the amount of PEEP you're using to try and optimize your venous drainage. And these are really applicable at any site across the province. As for arterial size, like I mentioned before, our CO2 is a potent vasodilator. So in a lot of neuro patients, we will target a lower PaCO2, so 35 to 40, sometimes 30 to 35, depending on your site and your team and how sick your patient is. And by keeping them on the lower side, because CO2 is a potent vasodilator, by keeping it on the lower side, we'll keep them a little bit more vasoconstricted, which is going to limit the amount of blood flow into the brain. In an ICP crisis, you might be able to see, or you might see that you will put a patient onto a bagger and just hyperventilate them, try and remove their CO2 as much as possible to try cause some vasoconstriction. That is a very short-term intervention, but it is helpful in emergency situations while you're trying to, give them 3% and everything else. The other thing that we can do for manipulating arterial size is drugs. So a lot of these patients will have target MAP goals, target cerebral perfusion pressures, just targeting higher blood flow to the brain. And we can titrate vasoactives like levo to do that. Also, we don't want them to have too much perfusion to their brains. So we might also give them antihypertensives if they are too hypertensive, and they might have something like a aneurysm that isn't fixed yet and stuff. So these are all real nursing interventions that we can do to try and reduce and manipulate the blood flow into the brain to try and reduce our ICP. All right. I know that was a lot and I talked very quickly, but any questions from anyone?
You spoke about hypertonic environment. Sodium levels, is there any threshold before you stop 3%?
Are there any thresholds before we start it?
The levels of sodium, yeah, or before you stop it, yeah.
Before we stop it. I don't really feel like I've seen higher than 150. That's kind of the most salty we'll let them get. Okay. And we also want to make sure that when we're adjusting our sodium or replacing sodium, that we're not causing too rapid of a change in sodium unless it's an ICP crisis, because you can get the what's called demyelinating syndrome.
Okay, thank you. Do you consider then mannitol after that, after higher than 150? Is that correct?
Yeah, particularly if you're in an ICP crisis. I know at VGHIC we will give both 3%. If it's still not working, then we'll give mannitol automatically after.
Did have one more question. Sorry, I took a quick picture so I could process some of the information. But under the Cerebral Oxygen Demand framework, in terms of the direction the arrows are pointing, was it intended under temperature for shivering for the arrow to be down instead of up like all the rest of the arrows?
Like right here?
Yeah,
it is, because temperature, when we try and regulate these patients, and because they aren't good at regulating their own temperatures because of where the swelling is, temperature can cause shivering. Like if we're trying to cool them, because a lot of them get neurogenic fevers. When we try cool them, they'll shiver, and shivering is going to increase your physical activity. So them just laying there and shivering is going to increase your physical activity, which is going to be detrimental to their demand increase. So it's something that we want to keep in mind. So you might, for shivering, we might just give sedation, see if that kind of lets them chill out a bit, give them some, we might even have to paralyze them just to reduce that demand for their brain.
Kelly, I have a question for you, because
Sure.
Back in the day when I was first learning neurocritical care, I learned from some nurse colleagues that if the patient was shivering, to put warm blankets around their feet and their arms, and it would kind of like trick them. Is that still practiced, or is that not anymore? Just curious about that.
It is, like, we still teach that at BCIT. Like, it is an approach you can do, wrap around their head, wrap around their hands, their feet, but just not their core. But in practice, more often than not, I'm just seeing us drug people, which is probably not great, but you can try and trick your patients that way. But if that doesn't work, then you do need to do some sort of medical intervention.
Thanks very much, Kelly, for your time and your expertise, and thanks to the BCIT team for sharing this knowledge with the rest of us.
Thank you for having me. I really appreciate it.
So thanks very much.
Thank you. And then just as a little summary, and then thank you, who I am, and then a reference. Gotta get those references in.
Yeah, totally. That's great. Thank you.
Thank you.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.